Acute kidney injury represents one of the most challenging conditions we manage in the NICU, and understanding its pathophysiology transforms how we approach both prevention and treatment. Let's build our understanding from the foundation up. At its core, acute kidney injury means the kidneys suddenly cannot perform their essential filtering function. Think of the kidney as a sophisticated filtration plant that suddenly experiences a major malfunction. The definition seems simple, an abrupt decrease in kidney function. But the mechanisms behind this breakdown reveal why AKI presents such complexity in our patients. The pathophysiology centers on disruption of two critical processes: glomerular filtration and tubular function. Picture blood flowing through millions of tiny filters, the glomeruli, where precise pressure gradients drive filtration. When this system fails, waste products that should exit through urine begin accumulating in the bloodstream. Simultaneously, the tubules lose their ability to fine-tune what stays and what goes, creating a cascade of imbalances. Three distinct mechanisms can trigger this disruption, and understanding each helps us target our interventions. Prerenal injury occurs when inadequate blood flow reaches the kidneys. Imagine turning down the water pressure to our filtration plant. The kidneys themselves remain structurally intact, but without sufficient perfusion pressure, they cannot filter effectively. This explains why prerenal AKI often responds dramatically to fluid resuscitation. Intrinsic renal injury involves direct damage to kidney tissue itself. Here, the filtration machinery sustains actual structural damage. Whether from toxins, inflammation, or ischemia, the glomeruli and tubules suffer injury that impairs their function even when blood flow normalizes. This explains why intrinsic AKI requires time for cellular repair, not just restoration of perfusion. Post-renal injury creates a different problem entirely. Obstruction anywhere along the urinary tract causes pressure to build backward into the kidneys. Imagine blocking the outflow pipe from our filtration plant. Eventually, the backup pressure prevents any new filtration from occurring. The kidneys may be perfectly healthy, but they cannot function against this resistance. The result, regardless of mechanism, follows predictable patterns. Waste products accumulate because filtration has ceased. Fluid retention occurs because the kidneys cannot excrete excess water. Electrolyte imbalances develop as the precise regulatory mechanisms fail. Each of these consequences creates its own risks. Uremia affects mental status, fluid overload stresses the cardiovascular system, and electrolyte disturbances can trigger life-threatening arrhythmias. Understanding these interconnected processes helps us anticipate complications and intervene before they become critical. Understanding the three categories of acute kidney injury helps us move from recognizing AKI to identifying its cause and guiding treatment. Each type has a distinct pathophysiology and clinical pattern we can identify at the bedside. Prerenal AKI accounts for the majority, about 85% of neonatal cases. The cause is straightforward: reduced renal blood flow to otherwise normal kidneys. With decreased perfusion, glomeruli cannot sustain filtration. It's a supply issue, not a structural problem. Common NICU causes include hypotension, from sepsis, dehydration, heart failure, and overdiuresis. Prerenal AKI presents with kidneys trying to conserve fluid and sodium. Lab clues include concentrated urine, high specific gravity, and fractional excretion of sodium, FENa to D, under 1%. Oliguria is typical as the kidneys work to restore circulating volume. The key advantage of prerenal AKI is its reversibility. Restore perfusion promptly, and function often normalizes. Intrinsic AKI results from direct nephron damage. Both filtration and tubular function are impaired, regardless of perfusion. Acute tubular necrosis, ATN, is the most common cause, frequently following prolonged prerenal states. Nephrotoxic drugs like aminoglycosides and vancomycin can cause direct tubular injury. Inflammatory diseases like glomerulonephritis or interstitial nephritis also contribute. Unlike prerenal AKI, the damaged tubules in intrinsic AKI cannot reabsorb sodium, resulting in FENa into 2%. Urine output may be low, oliguric, or normal, but the urine is typically dilute and may show proteinuria due to glomerular damage. These findings reflect kidneys that are structurally impaired and unable to respond to homeostatic demands. Postrenal AKI stems from obstruction between the renal pelvis and urethra, leading to back pressure that halts filtration. In neonates, common causes include posterior urethral valves, males, severe bilateral vesicoureteral reflux, bilateral ureteropelvic junction obstruction, or neurogenic bladder due to spinal defects. Clinically, postrenal AKI can be deceptive. Early urine output may be normal or elevated as the kidneys attempt to compensate, with oliguria appearing later. Diagnosis relies on imaging. Ultrasound typically reveals hydronephrosis or other signs of obstruction. Management requires timely decompression to prevent permanent nephron loss. Recognizing which infants face the highest risk for acute kidney injury transforms our care from reactive to preventive. Each risk factor reflects specific physiologic vulnerabilities that help us anticipate problems before they emerge. Prematurity, especially before 32 weeks, presents the most fundamental risk. Nephrogenesis continues until 34 to 36 weeks, so a 26-week infant may be missing up to 10 weeks of kidney development. These infants begin life with immature kidneys, GFRs around 10 to 15 ml/minute versus 30 to 40 in term infants, and tubules that can't concentrate urine beyond 700 milliosmol per kilogram. Their fluid regulation is fragile, and even mild stressors, hypotension, infection, or medications can overwhelm their limited renal reserve. Low birth weight, whether from growth restriction or prematurity, adds another vulnerability. Fewer nephrons at birth mean remaining ones must hyperfilter, like a short-staffed crew working overtime. This chronic strain increases the risk of injury and reduces capacity for recovery. Perinatal asphyxia delivers a dual insult. Blood flow is diverted away from the kidneys to protect the brain and heart. During ischemia, ATP depletes and membranes fail. Reperfusion often does more damage, with free radicals disrupting cell structures. Even with successful resuscitation, acute tubular necrosis may take weeks to resolve. Congenital heart disease limits kidney perfusion in several ways. Cyanotic lesions deliver hypoxemic blood. Left-to-right shunts like PDA reduce systemic output. Poor cardiac function lowers renal blood flow, while bypass surgery can trigger systemic inflammation, damaging glomeruli. Recognizing these risks is essential during perioperative planning. Iatrogenic factors are preventable but significant. Aminoglycosides accumulate in proximal tubules at toxic concentrations. Vancomycin causes epithelial injury, especially with high troughs. NSAIDs inhibit prostaglandins that preserve renal blood flow. Contrast agents contribute both direct toxicity and vasoconstriction. Even mechanical ventilation can reduce venous return, impairing renal perfusion. Sepsis amplifies these risks. Inflammatory mediators damage endothelium. Toxins injure tubules, and hypotension reduces perfusion. Capillary leak further depletes circulating volume, stressing already vulnerable kidneys. These risks drive clinical decisions. A preterm infant with a PDA receiving indomethacin faces triple jeopardy: developmental immaturity, hemodynamic compromise, and nephrotoxic exposure. This calls for proactive care. Optimize hydration, minimize drug burden, and monitor kidney function closely. Understanding risk empowers us to act early and preserve kidney function before irreversible damage occurs. The clinical signs of acute kidney injury, AKI, tell a precise story about what's happening inside the nephron. Each manifestation reflects a specific failure of normal kidney function, and recognizing these connections helps us detect AKI earlier and anticipate complications. Oliguria, defined as urine output less than 1 milliliter per kilogram per hour, is often the earliest warning sign. But why does it occur? When glomerular filtration rate falls, less fluid reaches the tubules. Picture a clogged coffee filter. No matter how much you pour in, only drops come out. In prerenal states, the kidney actively conserves fluid to restore volume. The clinical message is critical. That light diaper might be the first clue filtration is failing. This is why we monitor urine output so closely in at-risk infants. Rising serum creatinine follows a predictable but delayed trajectory. Creatinine, a muscle breakdown product, is normally cleared by glomerular filtration. When GFR drops, it accumulates in the blood. But here's the key. Creatinine rises only after significant loss of function. By the time it elevates, GFR has often fallen by 25 to 50%. That's why creatinine is a poor early marker, but a reliable indicator of established injury. Think of it as a smoke detector that sounds only after the fire has spread. Electrolyte abnormalities are among the most dangerous complications and reflect tubular dysfunction. Hyperkalemia arises as distal tubules fail to secrete potassium. Acidosis shifts potassium out of cells, and cell breakdown releases even more. Levels can rise rapidly, demanding close monitoring and cardiac precautions. Metabolic acidosis tells its own story. Healthy kidneys excrete acid and reclaim bicarbonate. When tubules fail, hydrogen ions build up while buffering capacity declines. Clinically, infants develop tachypnea to compensate. In preterms, this added work of breathing can quickly lead to exhaustion. The calcium-phosphorus axis reflects the kidney's role in mineral balance. Damaged tubules retain phosphorus, leading to hyperphosphatemia, which binds calcium and lowers ionized calcium levels. Reduced vitamin D activation further impairs calcium absorption. The result? Hypocalcemia and hyperphosphatemia can cause tetany or seizures, underscoring the kidney's wide-reaching effects. Fluid overload is the most visible result of failed excretion. When output doesn't match intake, fluid builds intravascularly, then shifts into tissues. We see this progress from weight gain to edema to pulmonary congestion. In neonates, even small volumes can impair breathing due to compliant chest walls. Importantly, diuretics may be ineffective if the kidneys aren't working. Each clinical sign maps to a distinct pathophysiology. Oliguria with concentrated urine points to prerenal injury. Dilute urine suggests tubular damage. Hyperkalemia with acidosis signals impaired distal tubular function. Understanding these patterns turns observation into informed intervention. Distinguishing between pre-renal and intrinsic acute kidney injury directly guides management. Diagnostic tests reveal the underlying pathophysiology, with each lab value offering a glimpse into nephron function. Fractional excretion of sodium, FENa, is the most powerful differentiator. In pre-renal states, intact tubules conserve sodium aggressively, producing a FENa at less than 1%. The kidneys are working, just underperfused. In intrinsic AKI, damaged tubules fail to reabsorb sodium, resulting in FENa and less than over 2%. This single value often defines the management path. Importantly, premature infants naturally have higher FEKNa due to immature sodium handling. A FENa of 3% may signal damage in a term infant, but be normal in a 28-weeker. Always interpret within developmental context. Urine osmolality offers another insight. In prerenal AKI, urine is concentrated, according from a 500 millosmo per kilograms, showing tubules can conserve water. In intrinsic injury, urine is dilute, according from a 350 millosmol per kilograms, reflecting lost concentrating capacity. This tests whether the renal machinery works, independent of perfusion. Response to fluid challenge adds dynamic information. In prerenal AKI, restoring perfusion with 10 to 20 milliliters per kilogram isotonic saline usually increases urine output within hours. If output rises and creatinine falls, it supports a prerenal diagnosis. No response suggests intrinsic damage needing supportive care while recovery occurs. Renal ultrasound plays two critical roles. First, ruling out obstruction by visualizing collecting systems. Dilated pelves point to postrenal causes. Second, Doppler can assess renal perfusion. Echogenic kidneys suggest intrinsic disease, while small kidneys may indicate chronic injury. Emerging biomarkers like NGAL promise earlier diagnosis. NGAL rises within hours, well before creatinine, and levels as courting 150 nanograms per milliliter suggest tubular injury. Think of it as a smoke alarm alerted before the fire spreads. A structured approach ties this all together. Low urine output prompts early assessment. Calculate FENa and osmolality to classify the injury. Use ultrasound to exclude obstruction. If prerenal injury is likely, attempt volume resuscitation and monitor the response. Each test refines the diagnosis, aligning precision with timely intervention, ensuring we catch reversible prerenal injury without delaying support for intrinsic damage. Managing acute kidney injury successfully requires aligning interventions with underlying pathophysiology. Rather than following a one-size-fits-all approach, understanding why kidneys fail leads to targeted treatments that address root causes while supporting recovery. The core principle is simple, but often overlooked. Treat the underlying cause. In prerenal AKI, this means optimizing perfusion. When sepsis causes hypotension, fluids and vasopressors restore the pressure kidneys need to filter. Think of it as restarting a pump that lost its prime. In cardiogenic shock, inotropes improve cardiac output and therefore renal blood flow. The key insight? Prerenal kidneys function normally when adequately perfused. In intrinsic AKI, the damage is done. Our role shifts to preventing further injury and supporting recovery. For example, if aminoglycosides caused tubular toxicity, discontinuing them halts ongoing harm. But stopping the drug won't reverse damage already done. Tubules need 1 to 3 weeks to regenerate. Intrinsic AKI often requires patience and supportive care. Nephrotoxic drug management is both common and preventable. Beyond stopping harmful agents, we must adjust doses of renally cleared drugs to avoid accumulation. A cephalosporin dosed for normal function can become toxic if GFR halves. This requires frequent reassessment as kidney function evolves. Fluid management highlights how physiology directs therapy. In prerenal AKI, aggressive fluid resuscitation makes sense. We're refilling an empty tank. A 10 to 20 ml curd Ledgo bolus often boosts urine output as filtration resumes. But with intrinsic AKI, the approach reverses. Damaged kidneys can't clear excess fluid, so continued resuscitation risks overload and pulmonary edema. Input must match output. If urine is 0.5 ml per kilogram per hour, intake should reflect that plus insensible losses. Hence, precise intake-output tracking becomes essential. Cumulative fluid balance reveals subtle trends daily weights may miss. A 10-gram daily weight gain may seem trivial, but over 2 weeks, that's 140 grams. Significant for a 1,000-gram infant. Monitoring cumulative balance helps detect dangerous fluid accumulation early. Supporting function and promoting recovery means maintaining electrolytes, correcting acidosis to reduce cellular stress, and ensuring adequate nutrition for repair. Validating additional nephrotoxins protects regenerating tubules. This physiology-based approach transforms AKI care from reactive to strategic. Faced with oliguria, we don't reflexively reach for furosemide. We first ask, is this prerenal and reversible with fluids, or established AKI requiring restriction? Understanding mechanisms allows us to intervene wisely, maximizing recovery while minimizing harm. Hyperkalemia is the most immediately life-threatening complication of acute kidney injury, and understanding its mechanisms allows for urgent, targeted intervention. Let's trace how kidney failure leads to this dangerous condition, and why our treatments work. 3 interconnected mechanisms drive hyperkalemia in AKI. First, reduced GFR means less potassium is filtered and excreted. Normally, the kidneys eliminate about 90% of dietary potassium. When GFR is halved, potassium clearance drops proportionally and serum levels rise, sometimes within hours. But this alone doesn't explain the rapid, severe spikes we often see. Second, metabolic acidosis causes intracellular potassium to shift into the bloodstream. As hydrogen ions build up due to impaired acid excretion, they enter cells in exchange for potassium, which exits into plasma. For every 0.1 drop in pH, serum potassium increases by roughly 0.6 milliequivalents per liter. This explains why acidotic infants can develop hyperkalemia so quickly. It's not just retention, but active redistribution. Third, cell breakdown releases massive intracellular potassium stores. AKI often coexists with conditions like asphyxia, sepsis, or rhabdomyolysis, all of which involve cell injury. With intracellular potassium around 140 milliequivalents liter and serum levels typically near 4, even modest cell death can cause rapid, dangerous elevations. When potassium exceeds 6.5, cardiac membranes become unstable, requiring emergency action. Treatment addresses the problem on multiple fronts. Calcium gluconate comes first, not to lower potassium, but to stabilize cardiac membranes. It restores the normal depolarization threshold, buying time for other therapies. Think of it as installing a surge protector before fixing the wiring. Sodium bicarbonate counters acidosis, reversing the hydrogen-potassium exchange. As pH rises, potassium re-enters cells. This is especially effective in acidotic infants, often dropping serum potassium by 1 to 2 milliequivalents liter within 30 minutes. Effective ventilation is essential to eliminate CO2. The glucose-insulin combo leverages cellular physiology. Insulin activates the sodium-potassium pump, shifting potassium into cells. A typical dose, 0.5 to 1 gram per kilogram glucose with 0.1 units per kilogram insulin. This lowers potassium by anthroposemolar milloc for milliequivalents a liter even in non-diabetics. Albuterol, via beta-2 receptor stimulation, also activates the sodium-potassium pump by a separate mechanism. Nebulized albuterol starts working in 30 minutes and enhances insulin's effect. Redundancy is valuable in life-threatening cases. These measures shift potassium intracellularly, but don't eliminate it. For definitive clearance, dialysis is required when medical management fails or potassium remains dangerously high. The decision depends not just on the number, but the broader clinical picture: EKG changes, treatment response, and likelihood of kidney recovery. Understanding these mechanisms transforms hyperkalemia care from protocol-driven. Renal replacement therapy is our final support when kidney function can no longer maintain homeostasis. Knowing when to start dialysis and how it replicates kidney function helps us make timely, life-saving decisions. Let's explore the physiologic principles behind these choices. The decision to start dialysis isn't based on a single number. It's about recognizing when the kidneys can't perform essential tasks despite maximum medical treatment. Each indication signals a physiologic failure that threatens survival. Refractory hyperkalemia over 6.5 milliequivalent liter is the most urgent. Cardiac arrest can occur within minutes. When calcium, bicarbonate, insulin, and albuterol fail, we've exhausted medical options. Only dialysis can remove potassium quickly enough to prevent arrhythmias. Severe acidosis with pH below 7.2 is another threshold. At this point, cell metabolism falters and heart function weakens. If bicarbonate can't correct the acidosis, dialysis is needed to remove acid and restore balance. Symptomatic uremia builds more gradually, but is dangerous. As waste accumulates, organ function declines. Seizures, pericarditis, or altered mental status mean toxin levels have surpassed what the body can tolerate. Infants, unlike adults, show symptoms at lower levels due to immature systems. Fluid overload unresponsive to diuretics is a common trigger. When the kidneys can't excrete fluid, it builds up despite diuretics. In neonates, just 10% excess can impair breathing. Their compliant chest walls and limited reserve make them vulnerable. Rising oxygen needs despite diuresis signal it's time for dialysis. Dialysis mimics kidney function through artificial means. First, we replace filtration. Using peritoneum or filters, pressure drives fluid and solutes across a membrane, just like glomeruli. Solute clearance follows diffusion. Dialysate low in potassium, urea, and creatinine draws these from blood. The principle is simple. Execution must be precise to avoid rapid, harmful shifts. Acid base and electrolyte correction relies on dialysate composition. Bicarbonate buffers acidosis. Dialysate potassium controls how fast we lower serum levels. Calcium and phosphorus must be balanced to avoid tetany or precipitation. Knowing these principles helps us choose the right modality and prescription. Dialysis isn't just about clearing toxins, it's about replacing a vital system safely, buying time for the kidneys to recover, and always aiming to stop support when healing allows. Peritoneal dialysis elegantly uses the body's own peritoneal membrane as a dialyzer, making it ideal for neonatal renal replacement therapy. Let's understand how it works and why we often choose it first. The mechanism is beautifully simple. We instill dialysate into the peritoneal cavity, where the membrane's vast capillary network acts as our filter. Waste products like urea and creatinine diffuse from blood into the dialysate, following concentration gradients, high in blood, absent in fresh fluid. Meanwhile, dextrose in the dialysate creates osmotic pressure that pulls excess water across the membrane. Higher dextrose concentrations, 1.5, 2.5, or 4.25%, remove more fluid. Why choose PD for neonates? No vascular access required, just a soft catheter through the abdominal wall. This avoids the risks of central lines in tiny vessels. More importantly, PD provides hemodynamic stability. Unlike hemodialysis with its rapid shifts, PD removes fluid continuously and gently, rarely causing hypotension in fragile infants. The steady biochemical control prevents disequilibrium syndrome. But certain conditions absolutely contraindicate PD. Necrotizing enterocolitis tops the list. Inflamed bowel cannot tolerate dialysate pressure, and we risk spreading infection. Abdominal wall defects provide no cavity to hold fluid. Recent surgery needs healing time without mechanical stress from fluid cycling. Diaphragmatic hernias allow fluid migration into the chest, compromising breathing. When PD is appropriate, we tailor the prescription to the infant's needs. Dextrose concentration determines fluid removal rate. Dwell time affects solute clearance. Short cycles for rapid potassium removal, longer for middle molecules. Fill volumes balance effective dialysis against respiratory compromise. This isn't just running fluid in and out, it's creating personalized kidney replacement using the body's own anatomy. When prescribed thoughtfully, peritoneal dialysis provides the gentle, effective support our smallest patients need. Hemodialysis and continuous renal replacement therapy represent two ends of the dialysis spectrum. One rapid and efficient, the other slow and gentle. Understanding their mechanisms helps us match the modality to the patient's needs. Hemodialysis works through rapid solute clearance using counter-current flow. Blood and dialysate flow in opposite directions across a membrane, maximizing concentration gradients. Think of it as two trains passing in opposite directions. This design extracts maximum waste with minimum dialysate. Ultrafiltration removes excess fluid by applying negative pressure, literally sucking water across the membrane. The entire process is remarkably efficient, clearing toxins in hours that peritoneal dialysis takes days to remove. But this efficiency comes with risk. Rapid fluid shifts can destabilize fragile neonates. Removing 200 milliliters quickly from a 3-kilogram infant represents massive intravascular depletion. Blood pressure drops, organs hypoperfuse, and we've potentially traded kidney failure for cardiovascular collapse. The rapid clearance of urea can trigger disequilibrium syndrome as osmotic shifts cause cerebral edema. This explains why hemodialysis, despite its efficiency, often proves too aggressive for unstable infants. CRRT offers a gentler alternative by spreading the work over 24 hours. Instead of dramatic 4-hour sessions, CRRT provides steady, continuous clearance that better mimics normal kidney function. The slower blood flows and gradual fluid removal rarely cause hemodynamic compromise. Picture the difference between draining a bathtub quickly versus a slow, controlled leak. The end result is the same, but the process stress differs dramatically. This physiologic gentleness makes CRRT ideal for our sickest patients. The infant on multiple vasopressors who couldn't tolerate hemodialysis often remains stable on CRRT. Continuous removal prevents the accumulation between sessions that intermittent dialysis allows. We can also provide better nutrition since we're continuously clearing the waste products of metabolism. Both modalities require anticoagulation to prevent clotting in the extracorporeal circuit. Blood contact with artificial surfaces triggers coagulation cascades. Without anticoagulation, circuits clot within hours, losing blood and requiring replacement. We typically use heparin, carefully balancing clotting prevention against bleeding risk. In high-risk infants, regional citrate anticoagulation provides circuit patency without systemic effects. The choice between modalities depends on clinical stability and treatment goals. Stable infants needing rapid correction might tolerate hemodialysis. Critically ill infants with cardiovascular instability need CRRT's gentle approach. Understanding these mechanisms transforms modality selection from preference to physiology-based decision-making. Acute kidney injury casts a longer shadow than many realize. Even when urine output returns and creatinine normalizes, the kidneys often emerge fundamentally changed. Understanding these long-term effects guides how we counsel families and plan follow-up care. Immediate outcomes are only part of the picture. Mortality rates of 10 to 15% reflect the severity of the conditions causing AKI, not just the kidney injury itself. Survivors often face prolonged hospital stays to manage complications, support recovery, and establish feeding. But discharge doesn't mean full recovery. Here's the key concept. Nephron loss is permanent. Unlike liver cells, nephrons don't regenerate after 36 weeks gestation. Once acute injury destroys nephrons, the remaining ones compensate. This hyperfiltration preserves normal creatinine, a silent period where labs appear stable, but strain builds. Each nephron takes on extra workload. Over time, this stress leads to glomerular sclerosis, scarring that reduces function further. As functioning nephron numbers fall, workload increases again, accelerating damage. What starts as an acute event can evolve into chronic kidney disease years later. With reduced functional reserve, these children live closer to the edge. A healthy child might lose 50% of kidney function before showing symptoms, but a child who starts with 70% has far less margin. Future dehydration, medication toxicity, or even pregnancy might trigger kidney failure when others would compensate. Hypertension arises from persistent RAS activation. The scarred kidney senses low perfusion and releases renin to raise blood pressure. This once adaptive response becomes harmful, increasing pressure and damaging more nephrons. Young children may require antihypertensives, a stark reminder of their altered physiology. The cardiovascular effects extend further. Chronic kidney disease promotes atherosclerosis through endothelial dysfunction, calcium-phosphorus imbalance, and inflammation. These children face elevated lifetime cardiovascular risk starting in infancy. This knowledge changes how we care for AKI survivors. They need long-term nephrology follow-up, with yearly blood pressure checks, urinalysis for protein, and creatinine monitoring. Families need guidance on maintaining healthy weight, avoiding nephrotoxic meds, and treating infections promptly. Most importantly, they must understand that today's normal labs don't guarantee lifelong kidney health. The goal shifts from surviving AKI to preserving every remaining nephron for decades to come. Bilateral renal agenesis involves complete absence of both kidneys, creating a pathophysiologic cascade that begins in utero. Without functioning kidneys, fetal urine production ceases, eliminating the primary source of amniotic fluid and resulting in severe oligohydramnios. The absence of amniotic fluid produces Potter sequence through mechanical compression of the developing fetus. Oligohydramnios removes the protective cushioning effect, leading to direct compression against the uterine wall. This mechanical pressure produces the characteristic compressed facies with flattened nose and low-set ears. Most critically, oligohydramnios prevents normal fetal breathing movements that require amniotic fluid for lung expansion. Without this fluid-mediated lung development, severe pulmonary hypoplasia occurs. The lungs remain underdeveloped with insufficient alveolar surface area for gas exchange. Growth restriction results from loss of amniotic fluid's nutritional contribution to fetal development. The combination of mechanical compression and nutritional deficit impairs overall fetal growth. The prognosis remains nearly universally fatal, with mortality approaching 100%. Death occurs primarily from respiratory failure secondary to severe pulmonary hypoplasia. Even with maximal respiratory support including ECMO, the degree of lung underdevelopment typically proves incompatible with life. This pathophysiologic understanding explains why bilateral renal agenesis represents one of the most severe developmental anomalies, where the absence of kidneys creates a cascade of effects that ultimately proves lethal through respiratory compromise. Unilateral renal agenesis demonstrates the remarkable compensatory capacity of the developing kidney. When only one kidney forms, compensatory mechanisms activate immediately, beginning in utero rather than waiting until after birth. The pathophysiology centers on compensatory hypertrophy of the remaining kidney. This solitary kidney undergoes both structural and functional adaptation, increasing in size through nephron hypertrophy, while simultaneously enhancing filtration capacity per nephron. The remaining kidney can achieve up to 75% of normal two-kidney function, which explains why these patients often remain completely asymptomatic. Normal amniotic fluid production continues because one functioning kidney provides adequate fetal urine output. This prevents the oligohydramnios and Potter sequence seen with bilateral agenesis, allowing normal fetal development and lung maturation. Clinically, most patients present asymptomatically with normal growth and development. The diagnosis often occurs incidentally during imaging for other reasons. However, we must screen for associated anomalies, particularly VACTERL sequence components, as unilateral renal agenesis rarely occurs in isolation. Long-term management focuses on protecting the solitary kidney. These patients face increased risk of hypertension and proteinuria due to hyperfiltration injury. The remaining nephrons work harder and may eventually suffer from this increased workload. They're also vulnerable to acute kidney injury since they lack renal reserve. Management requires nephron-sparing strategies, avoiding nephrotoxic medications, maintaining optimal blood pressure, and ensuring adequate hydration. Unlike bilateral agenesis, the prognosis remains excellent with appropriate long-term monitoring and kidney protection.